Thank you everyone for joining us today. Appreciate you choosing the blood cancer section of the breakout rooms for joining us in the second half of today's Experts on Call with the Ottawa Hospital Foundation. I am delighted to join my experts today in giving you a little bit of a behind the scenes view of what we're doing in blood cancer care and research advancements. This is a Zoom webinar based session, so your cameras and audio are currently disabled. To ask a question to our experts, what I would ask of you is to please use the Q&A function at the bottom of the screen. You'll see it somewhere around here. If you use that little icon, you can type in your question and we will do our best to answer that in the session itself. In the event that your question is personal in nature or is a little bit more detailed than would be appropriate for confidentiality or privacy reasons of this visit, we may end up having to not ask your question today. That is not meant to be offensive in any way, shape, or form, but it is a means to which we can move through some of the questions that are more generic in message or in tone. So if I can, I will introduce the panel to you today. Today we have Dr. Mitchell Savlov. Dr. Mitchell Savlov is the Director of the Leukemia Program and Co-Director of the Ottawa Hospital Hematology Biobank. He's a member of the Blood and Marrow Transplant Program at the Ottawa Hospital. He's been working with the Cancer Care Ontario and improving the care of patients with acute leukemia across the province. And he's also an associate professor at the Department of Medicine at the University of Ottawa. What I would like to point out to you is that he is one of our famous Dancing with the Docs. We have two of them today. And if you were to ask some of his patients, he is most likely to represent Mr. Bean, is one of the fun facts that he suggested. We also have Jeff Jackson, who is one of our technical supports from Encore. Jeff, I'm not sure if you're seeing the same screen I'm seeing, but you are currently on Spotlight yourself. So in the event that our guests are seeing Jeff on the screen, welcome, Jeff. But he is our support. The next expert we have on the panel is Dr. William Stanford. Dr. Stanford trained as a chemist, immunologist, and a stem cell biologist, and a developmental biologist. In 2002, he established his labs at the University of Toronto in bioengineering, where he applied his interdisciplinary approaches to including molecular genetics and systems biology to stem cell research and tissue engineering. That's a mouthful. Dr. Stanford moved his lab in 2011 to Ottawa, and specifically to join the collaborative partners within the clinical side. Currently, Dr. Stanford is a senior scientist at the OHRI, the Ottawa Hospital Research Institute, and a full professor at the University of Ottawa. He's an investigator at the Ottawa Institute of Systems Biology, scientific director of the Ottawa Human Pluripotent Stem Cell and High Content Imaging Core Facilities, and Canada Research Chair in Integrative Stem Cell Biology. And again, there's another mouthful for you. I'll be here all week. When he's not being a scientist and busy in all of those functions that I just twisted my tongue around, you can find him at the mosh pits of the local music festivals. So Dr. Stanford, thank you for joining us. And our last clinical investigator to join us today is Dr. Grace Christou. Dr. Christou is a clinician investigator at the Ottawa Hospital Research Institute and hematologist in the leukemia program at the Ottawa Hospital. She completed her fellowship in leukemia at the University of Ottawa and is completing a master's degree in epidemiology at the University of Ottawa. She is the clinical lead for Myelodysplastic Syndromes, and her research focuses on patient involvement in research and improving the use of patient-centered outcomes to guide clinical decision-making. Outside of work, she's an avid reader and a documentary watcher and enjoys making large messes in her kitchen with her two rambunctious boys. Ladies and gentlemen, this is our expert panel for today. I'm almost done talking, and we will get right into some of the pre-questions that I've arranged to help complement some of the questions that you may ask in the near future. So we'll take a few minutes now to let our audience know a little bit about each of our experts. Starting from each of you, if you could take a moment to let us know what is your current research focus and how it involves and impacts patients in Ottawa. Dr. Savlov, can I pass the torch to you first?
Sure. Yes, there. Unmute. Thanks, Rob. So as the director of the leukemia program and the lead in acute myeloid leukemia, as you said, I have helped to establish the leukemia program in Ottawa. Alongside the patient care, the most obvious part of our day-to-day work is a busy in research that we hope will contribute to helping patients today and others that we might help in the future. Some of our research activities are supported by many doctors and nurses and scientists, as well as a very dedicated clinical trials unit that helps us to coordinate the clinical trials that we offer some of our patients, that we're able to offer some new therapies to some of our patients. Our research is also supported by a biobank, which has been in operation for over 10 years. We collect a small sample of blood and bone marrow from our patients to store in the biobank. And these valuable samples allow us to collaborate with scientists like Dr. Stanford and others at the OHRI, combining the clinical information and the biological discoveries to help us understand the disease and the treatment better. All of these resources not only allow us to join other groups' studies, but allow us to initiate our own trials based on our local discoveries, which we hope will eventually impact the lives of patients with acute leukemia.
Perfect. Thank you, Dr. Savlov. If I could now ask Dr. Stanford, perhaps you can give a little bit of an introduction to our group as well.
Yes. So as you can tell, it's really important to have an interdisciplinary research group to be able to bring cutting edge therapies to our patients. And so I joined this group to be very complementary to Dr. Savlov and Christou. I'm a stem cell biologist, a real basic researcher, and I'm trying to ask questions about why does a cell do one thing versus another. In terms of stem cells, we ask, why does a blood stem cell, for example, proliferate and make more blood stem cells, or how does it do that, versus differentiate into the mature cells of the bone marrow and the bloods, including red blood cells and immune cells. So by studying these basic questions, and when I can learn about these cell fate changes, and then I've been applying those studies to the patient samples that we are getting from Dr. Savlov from the biobank. This allows us to ask the same kind of questions about why does a leukemic cell do what it does, and why won't it respond to chemotherapy? And in doing so, with Dr. Savlov and Dr. Ito, we discovered that that patients who are refractory or don't respond to leukemic treatment, to leukemia chemotherapies, they are missing an important protein, a master regulator, if you will, of cell fate. And so from that, we were able to do additional studies, identify further downstream the pathway, and identify several regulators that we could change their expression, and that would allow the leukemic cells to be responsive to the chemotherapy. And in fact, we're lucky that one of those drugs happens to be in clinical trials right now. So we were able to partner with clinicians and scientists in the United States to start to study this whole pathway in patients. Use our biomarkers to identify patients who might not normally respond to therapy, and then use this new this new drug combination to treat patients who wouldn't be normally responsive to chemotherapy. And we're looking forward to bringing a phase 2 clinical trial here to Ottawa.
Fantastic, thank you. Dr. Christou, can I ask you to round out this particular answer, please?
Yeah, so my work is really complementary to Dr. Savlov and Dr. Stanford in that while they are developing the treatments that will hopefully further improve the lives of our patients and hopefully cure a lot of the diseases that we treat, what's happened in the interim is that in the last 15 or so years, our patients are living longer with their leukemia or their myelodysplastic syndrome. By the way, Rob, great job on that in the intro. So my job is to make sure that we are asking the right questions that are relevant to how patients experience their malignancy. As Dr. Auer alluded to in the introduction, a lot of the treatments that we have worked very well to cure or keep cancer at bay for a long time, but they have come at a big cost. And as we are now getting more and more options, which is a great thing, we want to make sure that the patient experience gets reflected and that the questions that we ask in research are the right questions to ultimately help doctors make decisions and help patients live their best lives, whether or not they're cured. So, to that end, one of my projects that we started this with here in Ottawa was to form a Canada-wide Myelodysplastic Syndromes priority setting partnership in partnership with AMAC, which is the main organization representing patients with MDS and aplastic anemia, as well as other colleagues. And we asked both patients and their families, as well as frontline clinicians, including physicians, hematologists and not, nurses and pharmacists, what their priorities for research would be. So what questions do they want research to address regarding myelodysplastic syndromes? And we got over 200 questions submitted to us. And we mapped out the data. What did clinicians ask and what did patients ask? And the things that they agree the most on are the need for better communication around a complicated diagnosis like myelodysplastic syndromes and throughout the patient's trajectory. They also asked, how do I live better with my MDS? And how do I manage my symptoms? So of course they were very interested in a lot of the other things that we have alluded to here in terms of immunotherapy and understanding the genetics. But in the meantime, they want to know, how do they live better? And those are areas that are understudied to a large extent. I think Dr. Clemens talked about, for example, their trial looking at nausea. And those kind of things are only possible if we include the patient voice. And so that's the goal of my research and where I focus on.
Lovely. Thank you so much. So that hopefully gives everyone who's in attendance today a little bit of background on what it is that our experts are focused on into one component. What I might ask you to do is, you each brought up a little bit about clinical trials in your introductions. Could I ask you to expand a little bit more, where appropriate, on the clinical trials that you're working on or optimistic about, and what that might mean to the specific areas that you're working on? And if you've already answered that to a certain extent, we do have a couple of follow-ups. Don't feel obligated to use your full 3 minutes. We've already received 3 questions that I think we'll be able to put at the end of this session. So Dr. Christou, can I ask you to lead this time, maybe partnering with some of the commentary about the role the patient plays in helping to design these trials?
Yeah, our goal is for patients to actually be involved in all areas of research, and not just as kind of a representative or a tokenistic kind of way, but very much as a co-investigator. So the study that I spoke to you about was actually co-designed with a patient representative from AMAC, or the patient advocacy group, and we ran it by them and we piloted it with the patients as well, for things like usability, relevance of the questions, and all those kinds of things that we may not otherwise notice. One of the initiatives that I'm right now starting to work on that came out of the results of that study had to do with how to best transfuse patients so that they're spending the least amount possible in the medical daycare unit getting blood and getting the most benefit out of it in their daily life. And it's really exciting because I'm right now working with some of my patients to develop a study protocol from the very beginning to look at how we can use things like smartwatches to integrate data about patients' activity, their heart rate, things like that, along with quality of life measures that they can enter in the comfort of their own home, to see if we can predict a personalized transfusion schedule for that individual patient, as opposed to relying on a hemoglobin level or a regular schedule, which is what we do now. So that's kind of one of the exciting things that I'm really looking forward to working with them on.
So this is where I deviate from the script a little bit, because one of the questions might be most appropriately asked by or answered by you, Dr. Christou. We've had an individual ask about the impact of stem cell transplants to MDS and the steadily decreasing, I guess it's the hemoglobin level or the HGBs. Are there any new treatments under study in being studied? Now, the phrase is, once EPO stimulation and transfusions become ineffective. I apologize. I'm not a scientist. I'm not a doctor. I just play one on TV. Are there any studies going on right now for that? And are there any trials that, are there trials ongoing that they could be a part of?
Yeah, great question. And yes, there's some very exciting work being done in that area. For a long time, transfusions and ESAs were the only thing that we had for lower risk MDS. And we actually have one trial ongoing right now at the Ottawa Hospital that addresses the question of whether a new treatment we're looking at is effective in patients who wouldn't be eligible for an ESA or who did not benefit from one. So that's just one of the trials that is ongoing right now.
And so the questions are confidential and private. So to the person who asked that question, please speak to your medical provider, to your oncologist, to your team on how to explore the types of trials that are available at the Ottawa Hospital or clinicaltrials.gov. But again, with the assistance and help of your medical team. Dr. Savlov, could I ask you to expand on your clinical trials and perhaps an element of the trials that are most of interest to you, perhaps relating to the biobank? You're going to hate me,
Sorry.
Doctor. There you are.
So, right. So clinical trials are always an important part of our program, like I alluded to earlier, and everyone has talked about. And most importantly, they allow us to offer new therapies to patients that are not officially approved for general use. And as everyone has sort of alluded to, they provide a more personalized, hopefully a personalized medicine approach to one's care, where we are trying to tailor the therapy to the person, taking into account some specific aspects about their disease or of themselves. And the whole idea there is to maximize the effectiveness and try and minimize the side effects. Compared to what we do today, which is to apply the same treatment to all patients and hope that it works well in all. And today's technologies are allowing us to better understand the mechanisms of the disease, as Dr. Stanford was alluding to, and more quickly evaluate our patients to be able to decide on therapies. So in terms of the current clinical trials, which we're testing new drugs or comparing to the standard of care, we have, for instance, we have a trial using a radioactive antibody prior to transplant for patients who have failed to respond to the chemotherapies. And because this is an antibody directed at the disease, it is expected that it will be effective to the treatment, but minimize some of the side effects to the other organs. In older patients, we're about to open a trial using a 3-drug compared to a 2-drug combination, using drugs that are more targeted to the disease, again, attempting to maximize the effect and limiting toxicity. And then finally, our work with Dr. Stanford's lab is using samples from our biobank has helped us to identify this biomarker that Dr. Stanford was talking about, that we hope will one day let us know if patients' leukemia will be sensitive to the chemotherapy, and if not, we would be, if not, then we are able to offer maybe an alternative therapy. Without the samples, however, from the biobank, such translational collaboration between a clinician and a scientist would be impossible. So that's where the biobank, which sort of sits in the background, is so important to our work.
Thank you so much. Dr. Stanford, I'm going to let you wrap up this answer, but maybe give you a little bit of an introduction for our guests. As a scientist, not a lot of times do you actually, in other institutions, get to play in the clinical trial space. But one of the reasons you said you came to Ottawa was for this opportunity. Maybe give us an idea from a designing and phase 1 component of trial design and trial, where your role plays, what your role is in helping discoveries come to the patients.
Right. So I think as Dr. Savlov said, one of the reasons why we came here was, to be able to interact with clinicians such as himself and Dr. Priest too. As the reason for that is we really want to take experiments that we're doing in mouse models of leukemia, for example, and then using those biobank samples, we've been able to put human AML, so patients from the Ottawa Hospital, their AML into a mouse, and therefore we were able to study in a model patient their leukemia, and that was how we found that this, after we performed many experiments and identified this pathway, we took the drug that inhibited the pathway, added it with the two drugs that are normally given to patients, the induction chemotherapy drugs. And we took patient cells that did not respond to the chemotherapy when they were patients in the hospital. But when we put them in the mouse and gave them combination therapy, so the two normal drugs plus the new drug, that's when it killed the leukemic cells, and yet the mice survived. And so this transition from the basic science bench to the clinic has to have this intermediate part, and this is the part that really excites me, and one of the reasons why I came to Ottawa to join that. And so right now, we are involved in 2 clinical trials in the States, and in both trials, we're studying whether or not our biomarker that we've talked about already can identify which patients are going to do well in the clinical trial. And so this will allow us to better design clinical trials in the future. There's already data out there that shows that a cancer clinical trial is 10-fold more likely to succeed if there's a good biomarker for in part of that trial design. And so by developing these biomarkers, we're hoping that to improve the clinical trials from being successful, and therefore bringing new drugs to patients.
That's incredible. Thank you. One of the things I'm going to do is I'll take a little bit of a 10-second timeout to say thank you to everyone who's continued to stay with us. Many of you are supporters of the Ottawa Hospital Foundation and cancer research that is ongoing. So we're very grateful for your interest, not only in attending today, but for your past support. It's your support that has allowed some of these discoveries, some of these trials, and some of the base facilities to provide the foundation for our scientists and clinicians to do this work. So we are very grateful to you and for your support. I am going to take a couple of the questions that we've got from the audience. I'm going to reword a couple so that they can be asked. So if it is your question or sounds like your question, please know that I took the liberty of editing it so that I could ask it. One of the questions relates to lymphoma. So related, but maybe not something that everyone can answer. But if you could, if someone is in remission from lymphoma, and it should return, can you speak to the success rates of it going back into remission again? Are there any general statistics? And I'll leave that open to the 3 panel experts if you want to just come off of mute to speak. So again, if someone is in remission from lymphoma, and if it returns, are there current general rules of thumb on success rates for going into remission again?
Well, if it's okay, I'll start. I think to start with, unfortunately, I don't think we'll have a good answer for this, because there are many different types of lymphomas. So if it comes back, there are, depending on what type it is, the different therapies and different statistics or outcomes for those. So I think we'd have to know more specifics there. You need to know more specifically about the subtype of lymphoma, and like we've alluded to in a lot of what we've talked about, in terms of leukemia, but it also applies to lymphoma. Knowing more about the disease and the person will again help us to personalize, pick the right therapy for that person, if we have an option of different therapies, and then be able to, again, apply or know the right statistics for that combination of patient and therapy.
That's, I think, a completely fair answer. And again, best for that question, if it needs specifics, to go to their medical team. I've got 2 additional questions. There is one relating to COVID vaccines that I'm going to come back to near the end, because I think that will be relevant. But the second question that I'll ask first is, and forgive me if I say this wrong, but I'm going to do it again, Dr. Christou, I apologize. Myelodysplastic syndromes. Can you describe what those are? There's a question from the audience that would like to know what those are.
Yeah, that's a great question. And our understanding of myelodysplastic syndromes is actually evolving. So myelodysplastic syndromes is an umbrella term that describes a number of bone marrow disorders that all share one common feature, or a couple of common features, let's say, which is that your blood counts, one or more of the blood counts will be low, and that on a bone marrow, the bone marrow looks funny, the cells look funny. And so what we know about it is that this is usually a problem in the genetic makeup or the expression of the genes that control the factory, essentially, that makes the blood. And so it can range from a very mild and stable disease to something that is very severe and very rapidly progressive. And myelodysplastic syndromes affect mostly people who are older. The median age is somewhere between 70 and 75 for diagnosis. And because our population is aging and people are living longer, the number of people diagnosed with MDS is going up. But also our awareness of it is increasing. And so clinicians, whether they're in primary care or hematologists, are looking for it more and are formally diagnosing it more. And of course, because now we have more treatment options, we're looking for it because there's something we can do about it in a lot of cases. So that's what MDS is.
Thank you very much. I'm going to return to the COVID question because I think it's going to be on a lot of people's minds if they've stead with this. So I'm going to read the question such that I don't mess it up. As people with blood cancers do not have a good antibody response to COVID vaccines, now I'm taking this person's word for it, will there be any research done to determine the extent of antibody response to vaccines specifically related to COVID? Or are you familiar with any research going on that might be beyond the COVID vaccine type research going on for antibody response? Open to the room.
I can start if that's okay. So I mean, I think it's an interesting question. It's a question that we struggle with every day. In every clinic, there's patients who are asking something similar. Right. So I think the short answer is that most of the studies have been done in people who don't have cancer, but those studies are being expanded now. You know, there's lots of patients with cancer receiving the vaccine, and so those patients are being studied. There was just, you know, and as an example, there was just a paper published 2 or 3 weeks ago in patients with CLL, so a very common chronic leukemia, and how they respond to the vaccine. So the answer is that more information is coming. I don't know if Dr. Stanford has some more insight, or Dr. Christou, but the information is coming.
Thank you, Dr. Christou.
If I may add to that, is that the antibody response or the immune response to vaccines is going to be very different depending on the type of blood cancer people have and what treatments they're on, or how far they are away from their last treatment. So, you know, there's probably not going to be a single answer to that question, but hopefully with time and more studies being done in that population, we'll be able to better predict you know, the level of response that people have based on a number of characteristics.
Thank you. Very tough question to answer, given the nature of blood cancers themselves and the various composition and impact of things like vaccines or treatments, the personalized care, not only for fighting cancer, but also to fight and help fight other ailments that might impact somebody beyond their cancer journey. So thank you very much for answering that question. I want to be conscious of time. We've got 4 minutes left in the agenda. There is a question that I think is relevant to the audience, and that is, for some of you, you've explained why you chose Ottawa. Dr. Stanford, it was a great answer to that. I won't look for you to repeat that, but maybe you can tell us what you're most optimistic about from either the research you're conducting or the research you're being partnered in, what are you most optimistic about for the patients you work with or for the patients the Ottawa Hospital is helping? And this one I'll start, if it's okay. Dr. Savlov, start with you, then to Dr. Christou, and then round it up with Dr. Stanford.
I thought I was going to get it right the third time, but 3 strikes, I'm almost going to be kicked out of this. Yeah, so I mean, we witnessed the challenges of acute leukemia and its treatment, the challenges of the disease and the effectiveness of the treatments is sort of, and the toxicities, like we alluded to, but like we talked about, there's a lot of work going on that makes us optimistic and hopeful that we're going to be improving care. So the translational work that we are involved in, using the samples from our biobank, for instance, is identifying a biomarker to let us know which patients might respond to the chemotherapy, and it also suggests an alternative therapy. And this is, the exciting thing is moving us more closer and closer to this personalized approach or tailoring the therapy, hopefully to improve the outcomes and have happier patients.
Thank you. Dr. Christou, would you mind giving a minute?
Yeah, so this is actually a really exciting time to be a hematologist, I think, especially in our field, because our understanding of the pathology of cancer, what drives it, and having an unprecedented number of new possible treatments that are being developed. Alongside that, we're also, facing this renewed focus on the patient experience like never before. And we have the opportunity and the technology to marry these two things or aspects together so that we are truly designing studies that have real impact, not just on patient survival, but also on their experience of their disease. And Ottawa is a great place to be for that, because we've got scientists across the entire continuum of discovery and development. People like Dr. Stanford, and maybe people even further back in the basic science world, all the way to methods center scientists who help us with patient engagement and clinical trial design, et cetera. So it's really a place where you can pick your favorite place along that pipeline and be able to contribute.
Thank you. Dr. Stanford, if I gave you 30 seconds, could you use it?
Sure. So what's amazing right now is that we've taken a drug regimen, induction chemotherapy, that's been the standard of care for 40 years. And by adding another drug, we're doing a good job of tailoring it to the person who really needs it. So I think the real amazing thing is in the next 10 years, most of our drug treatments will not be a standalone treatment, but it'll be a combination chemotherapy. So like some of the therapies that Dr. Bell was talking about earlier today, and Dr. Auer, these by mixing and matching chemotherapies with immunotherapies and things like that, it's just a really exciting time to be a scientist, and so I think we're really at a good point.
Well, thank you very much. Listen, everybody, the time is almost up. It went by quickly. I apologize. I think we got to all the questions we needed to get to. I want to thank you for participating. Thank you for joining us today. Thank you for watching not only our experts speak, but the pre-log and the introduction to cancer at the Ottawa Hospital. Thank you to Dr. Christou, Dr. Savlov, Dr. Stanford for sharing your experiences and your knowledge. And now, with the assistance of my good friend Jeff, I'm going to ask that they transition you to the next stage. Thank you, everybody.